Hello, I'm Adelina and I'm delighted to join you, even if it has to be virtually this time. So I'm going to talk about caregiving, care receiving dynamics, and reflecting on the implications for family relationships in the 21st century, perceptions of caregiving, and social, familiar, and economic impacts on these intergenerational relations. So, first of all, I'd like to thank all the people, as usual, that my presentations draw on. I am very grateful for many learning opportunities, but the views that are expressed are just mine and not those of my funders or employers. So I'm going to start by thinking about what do we mean by long-term care and why it's an intergenerational endeavor. And of course, just a reminder of how much we are aging all over the world, and the fact that many countries, although they're entering a very highly aged situation, still do not have accessible, affordable, and high quality long-term care systems that can respond to even the current demand for care. In terms of what's the definition of long-term care, we can define it as the activities carried out by others to ensure that people with or at risk of loss of intrinsic capacity can maintain a level of functional ability consistent with their basic rights, fundamental freedoms, and human dignity. And as we're talking about caregiving, I have emphasized the fact that we're talking about activities carried by others, and it is about these others that we really need to talk about today. In terms of the practice of long-term care, it does aim to reduce, lessen the consequences of or compensate for disability, cognitive impairment, loneliness, improve quality of life. But something we increasingly see in long-term care systems is that they also aim to support family and other unpaid carers in their roles as caregivers. When we talk about what services are involved in long-term care, in the definition that I always use, we do mean also care in people's own homes. So this can be home help, meals, nursing care in the community, for example, daycare, or in substitute settings such as residential care homes, nursing homes, or even hospitals. Very important to emphasize that support is provided mostly by unpaid carers, but also other community actors, maybe neighbors, maybe volunteers, and also by formal care providers that can be in the public, private, or voluntary sector. And characteristics of these settings and the carers that work in this sector is that usually, or the majority of them, have low levels of training. And in terms of the activities they provide support with, the main ones would be with activities like everyday tasks, which could be dressing, bathing, shopping, cooking, cleaning, but there may also be more therapeutic activities or activities that support social participation and enable people to live, let's say, a normal life despite having losses of capacity. We come from a tradition where long-term care was provided mostly or entirely by families, with the public sector or the charities only stepping in when other care is not available. So to be the case of people who are both poor and have no family. Care is provided mostly by women. Usually systems start by providing some social services for destitute people, people without family support. And care is provided as well, in some cases, in long-stay hospital ward, geriatric wards, which is where, when you don't have an established system, people may end up in. And we might also have, and that's really increasingly recognized as very important, support from primary care and community health teams and workers who can actually reach people in their communities and offer at least some sort of support. In most countries, we also see the development of a private care market for very wealthy people. Quite often, this is also in the form of unregulated domestic workers who may be even living with the families and providing support 24 hours a day. And we see the emergence of institutionalized residential care facilities. And of course, during the COVID pandemic, we learned a lot about the problems that we can have in systems where these facilities exist, but they're not regulated, that are not known about, and this can make it very difficult, for example, in the context of the COVID pandemic, to make sure that they have the resources that they need in order to support people with needs. What we see is that in very traditional systems, quite often the human rights of people who give and receive care are not really taken into consideration. And that is something that we increasingly see the international agencies and advocacy groups highlighting as a really important need. So now I'm going to move on to talking about care needs, care receiving, caregiving dynamics, and allow me this indulgence, but I was just asking Copilot to develop using AI some images of what an older woman might look like in Spain on the left and in Singapore on the right in the year 1980 and in the year 2025. And it's quite interesting that they obviously think that in both countries, beige and having white hair is the way to go for women, older women in 2025. And it's interesting to see as well maybe the difference in facial expression that for some reason AI seems to think people have. And I don't really believe that people, older people in 1980 were less happy than people in 2025. But what it is really stark is that being old in nowadays is very different than what it was 40 years ago. And we also know that the people who will be old in the next 10, 15, 20 years will be very different than those who are old today. And what they will want, how they will want to live, their preferences when it comes to care, we can expect that won't be the same. We also know that there will be big changes in the health status of older people, and it's quite difficult to predict. But here we did an exercise in England when we were looking at how people age based on different health behaviors and health characteristics in midlife, and then we projected how they would compare to currently old people in terms of their life expectancy and the total number of years lived independently, that is, without any need with help with activities of daily living or with low, medium, and high dependency. And it's interesting to see that there is quite a big difference in what we can expect for men and for women. The projection is that men will be living will gain more life expectancy than women, and that would mean then that the difference in life expectancy between men and women is expected to decrease, which would mean that we will have more couples living together for longer and potentially providing care to each other. But we also see that men can expect more of those years to be independent. In fact, their healthy life expectancy is expected to grow faster than their total life expectancy, which means that we can expect less dependency, less time independency for men. For women, the situation is different. We actually see that the length of time in independence is lower than the total number of years gained, and we see that the bigger amount of that difference is due to increases in low levels of need, but also we do see an increase in the levels of high dependency for women. So there's obviously something about how women are aging in England and very aging at the time we did the study that would need to be addressed to support maybe a better way of aging for women. When we did the study, we also looked at the characteristics of the people who will have high levels of need in terms of whether they will also have dementia and how many other diseases they would have. And what we see is that the picture is quite different. In 2015, we see quite a few people in what we call the turquoise, green, or blue, I don't know how you see it, bit, where we have about 27% of people aging without dementia or one disease or more. about almost 50% of people with no dementia and just some diseases. But when we look at 2035, we see that the numbers of people living with dementia and 2 or more diseases is going to increase dramatically. And the number of people with what we call simple dependency, that would be without dementia and maybe at most 1 or 2 chronic conditions, is really going to become quite small. And this is very important because it's telling us that the complexity of the population who will be needing care is going to increase a lot unless we have changes in the risk factors and in our behaviors that mean that we can age more healthily. And this takes me to the next slide, which is using an image from the Lancet Commission on Dementia. And what we know is that we have important opportunities throughout the life course to change our risk of becoming dependent. In this case, is to change our risk of developing dementia. And that is an opportunity, but it is also an opportunity that requires some action, some policy action. It's not enough to tell people, oh, you have to eat better, you have to exercise more. We actually need to support them in changing these behaviors. And we also need to understand the inequalities around exposure to the risk of developing dementia. And we also have opportunities to treat and manage chronic conditions in the health system to reduce their disabling consequences and therefore the need for long-term care. So what can we do? Take up all opportunities available for prevention and reablement. We don't need to fear aging so much if we are independent and in good health. Make sure we have long-term care systems that are able to respond to a much larger number of people requiring care and support. And it's important to note that because of demographic aging, even if we see some improvements in, for example, the health of men in the future, we will still have many more older people and they will need much more support. And we make sure that the long-term care systems that we have are appropriate to the cultural context and respond to a variety of needs, preferences, and circumstances. And finally, make sure that we have future-friendly care systems. And I'll talk a bit more about that. So what do we know about caregiving dynamics? So we have had a look at how caregiving is changing in Europe. And I'm sorry, I don't have a lot of data on Asia, but I am based in Europe, and that is the area I know better. But we do see that over time there have been a very different trends between care within and outside the household. And basically that means by care outside the household, we mostly mean intergenerational care, so care provided usually by children to their parents. And in Europe, we have seen that men born more recently are less likely to provide care outside the household, whereas there hasn't been any change in women's provision. And this is telling us that we have different gendered responses to changes that are happening. The authors of this study have attributed this to increases in the retirement age, but also in differences in the labor force engagement and participation of women, with women having higher propensity to drop off the labor market. The same study also found that, in contrast, there has been an increase in care provision within the household. And this has been observed both by male and female. So this would be intergenerational care provided mostly from one spouse to the other. And one of the potential explanations for this is this decrease in the life expectancy differential between men and women, which basically means that couples are living together for longer and they're able to support each other. So what are the policy implications for Europe from this study? And I don't know if that's also the same situation in Singapore and in Asian countries, but what we do know is that we need to consider very carefully policies to support working age carers in maintaining employment, so perhaps especially women, perhaps having some support like day centers where the care is organized around the working day to facilitate that women can continue to work while they're also providing some hours of care to their relatives. And it is important as well that we consider policies to support older carers who maybe fail themselves, and that if we're not careful, we might put them at higher risk of developing dependency and needs for care themselves. So it's really important we consider and pay attention to these changes and their needs. A bit of a reflection, and it's something I often ask myself when I hear colleagues in Asia talk about filial piety. And I have done a little bit of research looking at what are we seeing in terms of the evidence on filial piety. And one thing that's interesting to consider, and perhaps here I bring a Southern European view compared to what would be maybe a Nordic view of family care, is that in Western societies, we also have the 10 Commandments that give us the obligation to take care of our parents. So although we come from a different Christian background, in my case, we still have this responsibility in our religion, but we also have it in the laws of many countries where offspring are legally responsible for the care of their parents, being in kind or being in cash. What we see in practice, though, is that countries are often quite reluctant to enforce this, and this is to do with a lot of pressures. And I think that the pressures that we are seeing are in common in Europe and in many Asian countries. One of them is the fact that we have increased labor mobility, migration, and that has reduced the prevalence of multi-generational households. And when I say migration, this can be within the country or this can be outward. So we have a lot of migration within the country from rural areas to urban areas, whereas the older people would be staying traditionally behind. And that changes very much how, when they develop care needs, their children are able to support them. We also see a growth in parents not wanting to be a burden to their children. And I think it is important to think of how this may be changing over time, especially as we are seeing much higher investment in education, and we need to think how maybe some of these parents who have invested so much in their children, having even university studies, would not want them to drop everything to go and provide care to them. So we do see that filial piety is increasingly being translated into financial support as a result of these changes. And we do see that maybe we need to think about the relationship between family and formal care, not as a binary choice. It's not that this either the family does it or you have formal care, but as a joint production of care that can be supportive of each other. And what we see is that the best outcomes tend to be when both forms of care coexist. And what I want to emphasize here is that although I'm mostly talking about care in the community and care at home, we also know that when people move into care homes, and we have evidence from all over the world, including from China, they still receive family care. It's not that you put people in the care homes and you forget about them. In many cases, people will continue to visit almost daily to support and help in the care home and in the care of their relative, even though they're no longer at home. And what we also have seen is that there are also big changes in attitudes towards caregiving. And again, I'm sorry, this is European evidence, but we did a survey in 2021 that we were able to then compare with 2007. And what we see is that there is an increase in the experiences of care, both in providing and receiving, now compared to the past. And this would be, I think, it mostly to do with the aging of the population. We do see that there is a reduced trust in the ability of the formal care systems to address the care needs of the population. We see that residential care home has become increasingly unaffordable from the perspective of people who need to pay for it. And we also see that more people have been providing an informal care in 2021 than in 2007. So we don't see that there is a decrease in the provision of informal care. It's actually growing. At the same time, we also see more people having to quit their jobs or work part-time as a result of caregiving, and this is clearly much higher for women. And we also see that people's expectations that they will need long-term care has increased, showing that perhaps there's also more awareness of the need for care and that this is something that may really be happening and that we'll need to prepare for. At the same time, there's been a decline in the public trust on the ability of the long-term care systems to respond. There is a decrease in the preference for informal care, particularly among women. People stating that they don't want to be a burden to their relatives. We see a very strong preference for care in the community, both informal and formal. And we see in Europe that there's a very high support for the public sector organization of care. And it was 97% 2007, 96% in 2021. And at the same time, declining support for placing the financial responsibility for care within the family, which is saying that people want to have some sort of financing for care that is public and it is at country level and doesn't put all the financial risk of needing care to individuals. And I think this is a good example of the fact that what we might see as the attitudes of care of today in one country may be completely different even for the next generations, but there are also some important trends and experiences that we need to learn from. And finally, I want to talk about the impacts of caregiving. And I'm going to state again that it's not that in Europe people leave everything to the state. Actually, the families are the main providers of long-term care in Europe. There's estimates that range from 66% of all hours of care are provided by families to 80%. And this is mostly family, could also be some friends and neighbors. And this is the case even in countries that have high levels of public expenditure on long-term care. The good news is that providing care, particularly to a family member, can have many positive effects, and this can contribute to personal growth, a deepening of the relationship of the care diet, and also it can deepen the relationship of the whole family. But there's also very clear and growing evidence that there is an issue of how much care you provide. So people who provide high intensity of care experience major negative impacts and fewer positive impacts. So to do better, you basically need to provide less than 10 to 20 hours of care per week. If you provide between 20 and 30 hours of care per week, you will experience, at least on average, very significant negative impacts on your physical health, your mental health, but also your financial situation. And this is something that we need to think about, because it might be that relying on unpaid carers now is only going to create problems of future poverty, especially among women who have not been able to contribute or save very much towards their pensions. It's important to also be aware that it's not always a choice to have to provide high intensity of unpaid care, and that this may be due to the lack of availability or affordability of formal care where you live. And finally, we do have also good evidence that lower availability of public formal care is associated with higher intensity of uncare provision. So in summary, what we know is that family care is actually a very good thing, but it can't be in too much intensity. So you want to be able to have some sort of balance between your own life and the life of yourself as a carer. And we are now very clear on the need to identify people who are providing very high intensity of care and making sure that there is some support to reduce this burden, be it perhaps with a bit of a collaboration between formal care and informal care, so people have better outcomes and less burdens. And finally, I'd like to finish with a slide and apologies if some of you have seen this before, that when we think about long-term care, it's actually a really complex ecosystem that impacts how people experience their care outcomes. And with putting the person at the center, one very important aspect is their personality, their situation, their characteristics, how resilient are them. That will really affect how the needing care will impact them. The care and support from family members can be very different for different people. Some people may be living alone and don't have any children, and these people exist and they do need care, they do need support, and we need to plan for them. Some people may not be able to get on with their families for other reasons, or we may have people whose children have migrated and they have not been very successful, perhaps, in bringing enough remittances to pay for care. And we do need to understand the age, the work situation, the life situation of unpaid carers, because this will make a very big difference to how they are impacted by providing care, and their availability as well. The quality of housing is really important, and we need lifetime universal design housing that enables people to live as independently as possible, and we have very good evidence of this, and actually there are exceptions, but in many countries this is not something that's often thought about together with care. We do need accessible and friendly environments that help people stay as independent and active as possible to maintain their health and to be able to continue to go out even if they have some disabilities. We do need strong communities. We do need to build on the community resources that we have in each locality. This will be different in each place, but it's definitely a strength that we have that we can do more with. We need health systems that are oriented towards helping improve the quality of life of people and to help them age well. And for that, they need to be person-centered. And we need long-term care systems that are generous enough, where the services are of enough quality, that are oriented towards the person and towards the community. And of course, there's other macroeconomic factors and situations that are going to affect people's experiences of care. And I've mentioned pension systems, labor markets, migration, housing policies. All of these will affect how people will age and their experience of care. Just to sum up a little bit, the kind of challenges that we have for relying in traditional care models is that we have many more people living to older ages, many more people living and aging with dementia and complex health needs. We do have fewer numbers of people of traditional working age in many countries, or we will have that soon. We are seeing major changes in the roles of women in the labor markets, migration within and outside countries, but also we have changes in people's expectations about how we want to live as we grow older. And we know how lack of formal care is particularly a barrier for women's labor force participation, and this is something that may condemn them to poverty and old age. And we also have very good evidence that lack of long-term care leads to avoidable and expensive hospitalizations, which is another good argument for investing in good long-term care. And just a bit of a reflection on what does a good long-term care system do. It ensures that people with long-term care needs can stay in good mental and physical health for longer, live in their own homes with as much independence as possible. And in their own homes doesn't mean the house where they have always lived. It may be that an alternative home in the same neighborhood is an excellent opportunity for them. And of course, we want systems that can help people enjoy their quality of life. We need to support families so that carers can continue with their professional careers if they're of working age, be protected against the financial aspects of caregiving. And in the case of older carers, ensure that they can remain in good health and experience good quality of life. We need a system also that can respond to the preference of the population. We need to make sure that it strikes the right balance between collective and individual responsibilities, and that reflects the views of the people in that country, that strikes a balance between public and private solutions, between cash for care and kind benefits, finding the right approach, And we also see that that the system needs to consider people's preferences in relation to care at home, care in the community. For example, daycare in Japan is very popular and seems to be a great option, or the preference or not towards care, congregate settings like residential care. And finally, I'd like to remind us that there's growing evidence that these preferences vary between countries, but also that they change over time. And it is important that we have dynamic long-term care systems that adapt. And I'd like to end with this illustration of a neighborhood, an ideal neighborhood for people with dementia in the Netherlands. And I do know that in Singapore, you take very seriously the place-based approach to care and to think of what are the elements that can make a neighborhood attractive and easy to navigate for people with dementia, and that can help people be as independent as possible while enjoying their neighborhood, their families, and everything that life has to offer. Thank you very much.